Good afternoon, everyone, and welcome to the Town of Newcastle's presentation of COVID-19, where we are and where we're going. We have a special guest with us this afternoon who's going to be presenting, and his name is Dr. Evan Cohen. Dr. Cohen is the medical director of the emergency department at Montefiore St. Luke's Hospital in Newburgh, New York. Dr. Cohen is also a Chappaqua resident and a parent with kids at Roaring Brook and Temple Bethel. He also sits on the Temple Bethel COVID task force. In late November, Dr. Cohen reached out to me out of concern about the increases in the number of COVID cases that we are seeing locally. With the holidays approaching and the cold weather, we're all expecting that COVID cases will continue to rise, which could in turn threaten our children's ability to attend in-person school. Dr. Cohen generously offered to take his time to help educate the community about how to reduce the spread from COVID, to discuss what's at stake, and to answer any questions that you have. On behalf of the entire town board, I want to thank Dr. Cohen for his time today and for lending us his knowledge, expertise, and experience. Newcastle is filled with brilliant minds and accomplished residents, and we are so fortunate when people like Evan step up to help out and to serve the community. Thank you. Dr. Cohen will give a brief presentation, after which he will be willing to take questions from anyone who's on the call. The chat function will be disabled during the presentation, but we will enable it when Dr. Cohen finishes presenting, and you'll be able to type your questions into the chat function, and he will answer them live here on the Zoom. So once again, thank you all for joining us, and thank you, Dr. Cohen, for being here with us this afternoon.
Thank you so much, Ivy, and thank you to Jill and Carrie for helping to get this organized, and thank you to everybody for taking some time out of their schedule to talk about everyone's favorite topic, COVID-19. So where are we and where are we going? We'll talk a little bit about the situation of COVID in our community, in our hospitals, what sort of treatments are out there. We'll talk about vaccines, and then as Ivy mentioned, I'm happy to take questions at the end of the presentation. Just a little bit about myself. As Ivy mentioned, I'm a father to Hunter and Cassidy and a husband to Melanie. We've lived in Chappaqua for a little under 5 years now. I've been a practicing emergency physician for the last 11 years since finishing my residency in Camden, New Jersey. And I'm currently serving as the medical director at Montefiore St. Luke's, Cornwall, and Newburgh, New York. I don't have any financial conflicts of interest as it relates to this talk, but I do have a serious interest in Chappaqua, in our town in Newcastle, and that's really why I'm here talking to you today. I very selfishly want to see my children be able to continue to be in school. For anybody with a 5-year-old and a 3-year-old, no, Zoom school is really miserable. So I'm really interested to see that continue and do anything I can to help our town succeed through this pandemic together. I'll start with a quote. "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has." And I really am confident that in Newcastle, we can get through this together and we can come out stronger. Again, I'll touch a little bit on the medicine and pathology of SARS-CoV-2, our situation in our community and locally, what we're seeing in the hospitals, what sort of treatments are out there, and what you can expect to hear about or receive if you were a family member sick. What can we do as individuals and as families to help get through this? And then I will talk about what I know about vaccines and the concepts of herd immunity, and again, we'll take some questions at the end. These terms are interchangeable. Often we hear them used interchangeably, but just for definition purposes, SARS-CoV-2 is the virus that causes the disease of COVID-19. I myself use them interchangeably, but a real scientist would tell you this definition. I made this presentation just about a week ago, and last night I was preparing and realized that already the numbers were just a gross misrepresentation of where we were at only a week ago. So in the United States, over 15 million cases, 290,000 deaths, and at this point, almost 70 million worldwide cases. This disease transmits mainly in respiratory droplets. And I would consider respiratory droplets to be large, heavy particles that come out of your nose or mouth when you cough, talk, or sneeze. And then typically within 6 feet, will go to another person and enter their body through their nose, mouth, or eyes. And that's really the main driver of transmission of this virus. There is some role, although I think much less than we initially were concerned about transmitting through contaminated specimens, like touching a dirty surface and then touching your eyes, nose, or mouth. There is some role for airborne transmission, and I would consider that to be particles that are smaller than those respiratory droplets that are going to kind of float through the air and get into someone else's body. And we think about that in a more than 6 feet away situation, like in a restaurant and you're a few tables away. And although that's not impossible, it is not a very common way, and it's not I believe what's driving this virus. And then finally, fecal oral transmission, which is as gross as it sounds. And if anybody wants to know what that is, they can put it in the chat box. I'll elaborate. So the viral shedding, there's a lot of kind of nuances to this, but once you become infected with SARS-CoV-2, you'll start to shed viruses and you can get someone else sick. And that can happen on average about 2.3 days before you yourself will develop symptoms. And that's really what makes this illness so difficult to control. Is unlike flu or the cold or Ebola, when you get sick with those illnesses, that's when you're typically transmitting to other people. But with COVID, you're walking around like everything is fine and you're shedding virus particles. And then you can continue to transmit your virus to someone else for an average of about 10 days after you develop symptoms. However, your viral shedding, which means you're going to continue to test positive on a PCR test for an average of 18 days, but it can take months until your body no longer has those viral particles being detected in the back of your nose. It doesn't mean you'll be sick for that long or infected for that long, but the test may continue to be positive. Out of all the questions I get from friends, family, neighbors, what defines an exposure is probably the most common because people want to know what to do. And I don't have a clear answer for that. What we use in the hospital is if two people are within 6 feet of each other for 15 minutes with at least one party being unmasked, that's a significant exposure. You have the other end of the spectrum, which is you're in your basement locked away and you haven't seen anybody in 10 months. And then there's really everything in between. Again, airborne transmission is not a major driver, but not impossible. So you could be in a restaurant on the other side of a restaurant and somebody had COVID and you could get struck by lightning and get COVID that way. Again, it's not driving it, but that's kind of the best answer that I have at the moment. And there are so many different situations. Every situation is unique. What was your exposure time? Were you wearing a mask? What was the person's viral load? Often it really is case by case, as far as was it a real exposure or significant exposure or not. The things that will impact the transmission, are you going to get sick or not, are how long was your exposure? So if you walk by somebody on the street with COVID and you pass them for 2 seconds and you're both wearing a mask, that's a minuscule exposure and it's very low risk. And nothing in medicine is 0 or 100. That's very low risk. Were you using preventative measures like a mask, like hand washing if you touch something dirty, or a face shield? And when you combine those two factors, I think about viral load. And that really means how many particles of virus went into your body or were you exposed to. And we know that a lower viral load makes it less likely that you're going to get sick. And if you get sick, it's less likely that you'll get very sick. And the opposite is true for a higher viral load. So even if you have to be exposed or you're going to be exposed, you want to wear your mask and whatever other protective measures are appropriate to minimize your viral load. There are always individual factors, somebody's health status, are they immune compromised? Are they a smoker? Getting sleep, appropriate amount of sleep at night can impact your likelihood to get sick. We know that household members are going to be the highest risk to transmit to each other, and that's not surprising. And also not surprising that the spouse is typically going to be the highest risk person to contract. I think it's important to talk a little nerdy and just explain the concept of R naught, which is something that the news junkies probably hear about. And that's the effective reproduction number. It's written as R0. And that's the average number of people that one person will pass the virus to. And for SARS-CoV-2, that's somewhere between 2 and 6.6. What's hopeful is that we can impact this, and I'll explain how. But just for an example, for comparison, seasonal flu, the R naught is around 1.3. But with a vaccine, we drive that below 1, and therefore our world does not get overrun by flu. Measles, on the other hand, one of the most infectious diseases that's ever existed in human history, had an R naught of somewhere between 12 and 18. And again, with a vaccine, we were able to drive this below 1, and then the disease goes away. I just want to elaborate on this a little bit more for the math geeks. Getting the R naught to below 1 is really important. It's the key to controlling the illness. For example, in the first example, you have an R naught of 1.5. 100 people with COVID after one cycle are going to transmit and infect 150 people. Those 150 people after one cycle are going to infect 225 people, who will infect 338, 438, so on. On the other hand, if we can get an R naught of 0.5, those same 100 people will infect 50 people, who will infect 25 people, who will infect 13, and eventually the disease becomes controlled or goes away. This just illustrates an example of an R naught of 3 for COVID-19. And you can see that the one person infects 3, 9, and then my multiplication falls off after that, but the picture shows that it gets ugly quickly. Which brings us to the point of super spreading. And you see our super spreader anti-superhero, the feeder of a speeding virus, more petulant than a selfish toddler and able to stop all momentum in a single night. This is what we want to avoid. A super spreading event is clusters traced to a single index case, and it's a huge driver of our COVID problem. And the risks, as we know, are prolonged group exposures, crowded indoor space, and lack of wearing masks. And out of all the research I did in preparation for this talk, this was probably the most impactful to me, which is a group of researchers at MIT ran a simulation, and they found that when everyone was limited to at most 10 contacts, we found that COVID would have rapidly died down. And maybe one of the best ways to stop the pandemic is just to avoid super spreading. And we can do that by limiting the number of contacts we have. And I think this may be the most important thing that I took away from my preparation. So when people get sick, most people are going to do really pretty well. They'll have asymptomatic spread or carriers, or they'll have mild illness like a flu. And there are about 20% of people will have more severe or critical disease. The risk factors are going to be age over 65 and the complex medical conditions like coronary artery disease, diabetes, hypertension, COPD, cancer, chronic kidney disease, obesity, and smoking. And then there are genetic factors, which I don't believe are very well understood yet, but scientists are getting there, and viral loads, which we've talked about. I think one of the hardest things for me with this disease is just that the COVID does not always follow the rules, and we do see those cases that we're surprised by, the 25-year-old healthy person that has really fatal or debilitating illness. And as somebody who still considers myself somewhat young, that's what's scary about it on a personal level. So the incubation is the time that you're infected with a virus until the time where you start feeling symptoms. And it's up to 14 days, but most people within 4 or 5 days are going to start feeling symptomatic. They're going to get pneumonias, muscle aches, diarrhea, lack of smell, headache, sore throat, vomiting, runny nose, and abdominal pain, which we would call like flu-like syndromes. And then in the second phase, and I'll talk a little bit about this as well, in that second phase, which is after the first week, people will or have risk to develop complications, which is really the serious part of this illness. And that's, respiratory failure, abnormal heartbeat, heart attack, heart failure, pulmonary embolism, stroke. These are really clotting issues and inflammatory issues. And then rarely, but still out there are these autoimmune issues like Guillain-Barré syndrome or this Kawasaki-like syndrome in children, which are certainly alarming and scary. And then about 10% of people will get a secondary infection. And that means you start with a virus like SARS-CoV-2, and then you get a bacterial infection on top of that. This seems to be about 10% of patients. And I just write no Z-Pack. I would just take a few seconds on my soapbox for antibiotic stewardship. That, for overwhelming majority of people, antibiotics are really not going to show benefit. And antibiotics do have side effects. So just to have that discussion with your doctor if it's mentioned. And most people are going to feel better in a week or two. There are those long haulers, which I believe the scientific community is learning more about every day. In New York City, they've opened an institute to study this. But some people do have weeks or months of coughing, fatigue, body aches, heart racing, shortness of breath, which is pretty alarming to me. Testing, obviously very important, and I just want to separate it into really 3 different ways to identify the virus. The polymerase chain reaction or PCR test, I would consider the gold standard. What that test does is it will pick up viral detection before you get sick, which is really valuable in controlling and helping people quarantine when appropriately. It'll also identify the virus when you are sick. And then we talked about that shedding period where you can continue to shed virus for weeks or months after, and the PCR will still pick those up. Then there's the rapid antigen test, and that's a little newer. And we see these in urgent cares and hospitals and doctors' offices. These are the 15-minute one. It doesn't quite biopsy your brain when they go in. It's just the front of the nose, so a lot more palatable. And that test is really good for picking up patients that are acutely sick within the first 7 days of symptoms. But what it's not so good at is if you're pre-symptomatic, it's not so good. So not to rely on it for that purpose. And if you are going to a doctor's office because you want testing due to an exposure, that needs to be taken into consideration. And then finally, the antibody, which I think a lot of the excitement has, gone down over the past few months, but this allows doctors to know, has your body ever seen the SARS-CoV-2 virus? And this is not that helpful for looking at active transmissible disease, but certainly if you're thinking about it in terms of, getting the vaccine or other, factors you want to consider, it's interesting to know. So where are we? We are in a bad situation right now. This is a national map, and it kind of ends towards the end of November. And unfortunately, the curves just continue. But in the yellow line, these are the new cases. And again, before November ended, we were approaching 200,000. The green line shows the new hospitalizations, and the blue line shows the deaths. And what's important for us to realize in the healthcare field is that the hospitalizations are going to lag behind the cases by a week or two because it takes people a week or two to get sick. And the deaths are going to lag behind the hospitalizations by a week or two because it takes people another week or two to get really sick. So, these are the sorts of things that are really important as we think about and prepare for what is the fallout after Thanksgiving or Christmas or any other, major event where people are getting together. In New York, it doesn't look a whole lot better. We're still increasing pretty rapidly our case counts and hospitalizations. And then in Newcastle, again, this is a slide that I updated this week, but 427 cases since the beginning and 57. I think that what's important to me when I venture into the world is the prevalence in the community. And in August and July, it really felt like nobody had COVID, or maybe it was one person in the town. And you had a sense of safety, and that was probably appropriate. And now with 50 or 100 people, some of them, feel sick, some of them don't, some of them are perfect at quarantine, others aren't. But the chances are, if you get together with a large enough group, you're going to interact with either somebody who has COVID or somebody who was just with somebody who had COVID. So just your probability of having a degree of separation to COVID certainly goes up. In the hospitals now, it's pretty concerning. The capacities are, the occupancy is going up, pretty rapidly, and most hospitals are nearing their capacity. The governor actually just mandated an increase in hospital capacities by 25%. So that means creating more bed and more space where it didn't exist before. And we practiced this in March and April, so we know how to do it again. But what's different this time around is that the needs of the healthcare system are national and not local. In a lot of ways, in March and April, we were lucky because New York was on an island suffering, and Colorado was fine, and Texas was fine, and we were able to pull in nurses and doctors and respiratory therapists from those states, and they came to help, and it was tremendous. And if anyone has seen one of those red maps on the news recently, we know that everybody's in as rough shape as we are or worse, with the exception of Hawaii, really. And so there's not a lot of extra healthcare personnel to come and help. And it's created, certainly a shortage and a real need. So that's one challenge. I think the burnout just becomes cumulative. People have been dealing with this for almost a year, and it weighs on us. I was talking to a nurse that I used to work with just this week, who was telling me that in a emergency department with 40 beds, they were boarding or holding 30 patients. And that means that those patients are sick enough to be in the hospital, and there's just no beds in the hospital, and so they sit in the ER and wait. And as an ER doctor, selfishly, that means that when you have a new patient that comes in, you're now working with them in the hallway where you don't have a good place to see them. And, that's a challenge for care, and it's a stressor on the nurses and the doctors and everybody else. And, this nurse was telling me that, people are walking out, they're quitting, and they're frustrated, and they feel it's unsafe. And similarly, just recently hearing from an ICU colleague who dealt with a sick COVID patient for 30 days on a ventilator and had a negative outcome, and decided to quit that day. And so, the burnout is real. I've seen doctors that have gotten into drugs and alcohol, and the stress is real. It's not normal to see the amount of death and suffering that we're seeing, and it certainly is taking a toll on our community. And personally, I have quarantine fatigue. I'm so sick of this. And, that's a stressor. Just nobody wants to go into the winter and not see their friends and family and not go to the playgrounds and not go to the movies and restaurants. It's just enough. And that's a real stressor. I'll talk a little bit about just length of stay and just another challenge with this illness. On the left side of the screen, you'll see, this is an old slide, but on average, in 2003 at least, and this number is going to be even less now, people that came into the hospital for any reason stayed a little less than 5 days. And on the right-hand side of the slide, you see how long patients with COVID stay. And it's pretty clear to see that there's a large percentage of patients with COVID that are staying in the hospital for 10 days, 15 days, 20 days. And I just think about the saying, you can come in, but you can't leave. And what happens is the bed situation becomes more full and more full and more full, and you're not getting an exit of patients to create new capacity. So, that's really one of the major drivers of the issues with capacity from this illness. To understand some of the treatments, I think it's just important to touch really briefly on the course of the illness. So we know that there are a few days of pre-symptomatic viral replication. You have about a week of what we call a viral phase, which means the virus is replicating in your body and making you sick with flu-like symptoms. And then that's followed by, a multitude of different steps, but it's really a cytokine storm phase, which is an increase in inflammation in your body, and your body's reacting to a threat that really is no longer there. It's irritating your blood vessels and ramping up your immune system. Sometimes your immune system can go haywire and attack itself. These are some of the drivers of the therapeutics that we use in the hospital. Now, most people are going to be fine and they have mild symptoms and they stay at home. They should be quarantining, monitoring their symptoms, talking with their doctor, making sure they're getting adequate rest and nutrition, and just being aware that if they got more sick, they should get help. The patients that are in the hospital, and these treatments are really what we're using in the hospital. Supportive treatment with oxygen to make sure your oxygen levels are safe. Proning we found to be really important, which means rotating a patient instead of just being on their back all day, rotating them on their side or their stomach, and that allows blood and oxygen to get to different parts of the lungs and has really improves dramatically a lot of patients' breathing. And convalescent plasma, which has antibodies in it, antiviral medications like remdesivir, and then most recently, just in the last week or two, there was emergency authorization for bamlanivimab, and there's another drug as well, another monoclonal antibody, which is even harder to pronounce than bamlanivimab, which we call BAM-BAM. And those are drugs that are currently authorized for patients that are not sick enough to go in the hospital, the monoclonal antibodies. So that's something that if you're at high risk because you're older or have COPD and you get COVID, that's the sort of thing that your doctor may have an interest or way to prescribe. These are still kind of new and the access is limited, but we'll be ramping up. And then in March and April, we thought that putting everybody in the ventilator was the best thing. And we learned pretty quickly that it's probably not. Once people are on a ventilator, it's extremely difficult to take them off a ventilator. And that's what I'd consider a Hail Mary, because that's not a great way to spend a few months in an ICU on a ventilator. There are treatments for the cytokine phase, that inflammatory phase, and this is really revolving around steroids like dexamethasone, which can tell your immune system to cool out a little bit in that second week of illness, that it shouldn't be reacting so strongly to the threat that is no longer there. Again, antibiotics, and just around 10% of those cases, and anticoagulation medicines like aspirin or Eliquis or Xarelto to prevent some of those clotting complications. And then I list other, there's something new on Facebook or Google or CNN every day, vitamins, ivermectin, anti-malarial drugs. And I would say really those are not widely adopted and accepted as things that are impactful to COVID-19 in a significant way. And just as a community, we need to be careful that every medicine has side effects, and we need to be careful about what we're putting into our bodies, especially if there's not really proven science showing that it's going to give you a benefit. And just to touch on the steroids has also been shown that if you're not very sick with COVID, it actually can make things worse. So these are all things that really you should be talking with a doctor about your situation. What can we do as individuals? And we can do a lot, but identify your priorities. I mentioned my priority, other than trying to keep myself and my family healthy, is I really want my children to be in school. That's so important to our family and my children. Who's in your bubble? You know, there are people that just have to see their parents or their sibling or, you know, their best friend, but, you know, have a bubble and try to stick with your bubble. Um, Avoiding large gatherings. Recognize a high risk situation, don't put yourself in it. Again, as the prevalence becomes so high, the chances that you're going to get that phone call in 2 days and say that, you know, at this party or restaurant or game, somebody had COVID, the odds are pretty high that that is going to happen. And the larger the group, the worse your odds. Wear your mask, wash your hands, keep the rest of your body as healthy as you can. So I kind of think sometimes as I'm exercising now, I'm like training for COVID. You know, if you can keep your heart and your lungs and your weight under control, you're going to have a better chance at, you know, weathering the storm if you do get sick. Recognize exposures and know when to, you know, take yourself out of that bubble and put yourself on quarantine and let, you know, people that you've been in contact know I may have had an exposure, and then, you know, you can work through it. How do we figure it out and get tested and get quarantined? But the first thing is don't make it worse. Don't be a super spreader. Be a role model. We all have impact on our friends and our families and our coworkers. Everybody watches, not just with COVID, but everyone. We're very astute people, and we watch what other people do, and you know, we can have an impact. I wrote an essay a few weeks ago on COVID and just kind of my experience with COVID, and you know, some people said that was really nice and it was well written and that felt good. But what really was so impactful to me was a few people said, you know, Evan, I'm not going to have a Thanksgiving party this year because of your article. And I felt like that alone made it worth it. And maybe that prevented somebody from getting COVID. And support each other. This is hard for everybody. And nobody is perfect. I'm far from perfect in my COVID behavior. I'm doing the best I can. And when I slip up, I want to be supported so I can do better tomorrow, not chastised. And then, you know, flattening the curve is still cool. We're talking about this all day, every day in March and April, but, you know, this is important again, and it's still cool and it's still important. Which just brings me to mental health, and we talked about this, but, you know, this is so impactful, and the winter is coming, and depression is real, and COVID depression is real, and this is tougher on some than others, but, you know, make a plan for the winter. Think about, you know, fun things you're going to do when it's snowy or when it's rainy, or, you know, to stay healthy, or, you know, to be able to engage with your friends and family. And we all need to recognize those people that may need that phone call, or, you know, that drop by, or whatever it's going to be. But, you know, check in on people. You know, we need to support each other. And if you need help, you know, get help. Things can always be better, and, you know, just don't be afraid to reach out if you need help. And then keep each other accountable. You know, again, I'm far from perfect, and it's almost a weekly occurrence in our household that I come up with a great idea to see certain people or do something, and my wife has to say, Evan, you know better. And I sigh with a kind of disappointment, and then recognize that, as always, she's right. So it's important to keep each other accountable. It's no different than if you were dieting and you had a partner or exercising. You know, we need to lift each other up. What do you do if you're exposed? The first thing is just don't make it worse. You know, take yourself out of the bubble. put yourself on quarantine. The quarantine guidelines I know have changed recently, from 14 to 10, and then you can do shorter if you're getting tested, but double check the CDC guidelines because it changes frequently. There is some role now for a shorter quarantine period if you're getting a negative test. That test should not be on day 1 or day 2. If you were exposed, assume that you have COVID and you're going to pass it to others. And really not until day 4 or 5 or 6 with a negative test would I feel comfortable with a shorter quarantine. And if you're not going to get a test, then you should go towards that longer, 10 to 14-day quarantine. If you're feeling a little sick, talk to your doctor. Again, don't self-medicate. A lot of the things that are out there are not scientifically proven and can make things worse. So talk to your doctor about recommended and available treatments. And then just public service. If you feel short of breath when you're walking from your couch to your bathroom, or you're getting chest pains, or you're lightheaded, or you can't perform your activities of daily living, we call ADLs, those are all signs that you probably are not able to handle that phase of the virus at home. And, the emergency department is there to help. I'd like to talk a little bit about something more uplifting, and that's vaccines. And I think there's a lot of really exciting, hopeful news in the atmosphere the last week or two. There are multiple different companies working on vaccines, and I'd imagine that we'll need all of them to really get through this. But the first ones are this Moderna, which is an mRNA vaccine, and the Pfizer mRNA vaccine, with AstraZeneca kind of close behind as an adenovirus vaccine. Yesterday, they started vaccinating people in the United Kingdom. I put 12/10, but I believe they started yesterday. And I'll talk a little bit about side effects, but I believe they paused their vaccination program midday. All these vaccines are very effective at preventing people from getting COVID. And if you do get COVID, extremely effective for preventing serious illness. And what we want is herd immunity, which means that the herd, the protected people, are enough that it makes it so unlikely for others to get sick that are not protected. For example, and for COVID, we need about 200 million people to have immunity until we can accomplish herd immunity. And scientists come up with these estimates based on the R naught. Measles, for example, we talked about that really high R naught, and measles needed a 95% vaccination rate so that we could accomplish herd immunity. Because COVID is less contagious, you need fewer people to be vaccinated. And this can be a combination of vaccination immunity and infectious immunity. So the silver lining out of however many millions of people getting infected is that, probably by the time vaccines are widely available, we're going to be in the 20 to 30 million cases of COVID recovery in the United States. So that's kind of one step on our way to herd immunity. But I certainly would not be a proponent of continuing that as our way to get there. The vaccine, just whoever came up with these, it's unbelievable and really a marvel of modern medicine and science. The mRNA is a message. It's messenger RNA. It gets injected into your body. It tells your body to make the spike protein that's on the coronavirus. Your body then recognizes that spike and develops antibodies to it. And then that messenger RNA is gone. It's no longer in your body. It gets broken down. And that spike protein is gone. It gets degraded and reused or recycled as protein, just amino acids. All that's left is your body's memory of that spike protein. And if you see SARS-CoV-2 in the future, your body will remember that spike protein and be able to rapidly upregulate antibodies to it. The side effects in the initial studies, and we'll learn more, I believe that the FDA is reviewing these vaccines today. for emergency use authorization. And we'll learn more as they publish their findings. But from what I'm aware of, the side effects are mainly like what you'd see with a flu vaccine or a shingles vaccine: fevers, fatigue, chills, redness or swelling to the arms. And I know was on the news yesterday and today, allergic reactions. And that can be to anything that you put in your body, whether it's peanut butter, Tylenol, flu vaccines. They're surrounded by molecules of protein or sugars or cholesterols, and your body can have an allergic reaction to that. So yesterday, to my knowledge, 2 people in all the United Kingdom had a severe allergic reaction to the Pfizer vaccine. And they said that for now, people with history of serious allergic reactions, should probably wait on getting that vaccine. These vaccines need 2 doses, so you get a booster. And I think everybody needs to make their own risk-benefit analysis. What's my risk of contracting COVID? If you live in Sydney, Australia, your risk is pretty low. If you live in Westchester County, your risk is pretty high. And what's my risk of getting sick? What are the underlying medical conditions? I used to fear dying from COVID, and now I fear never being able to play basketball or tennis or go skiing with my children. So just, what are you afraid of and how likely is that to happen? And what's the risk of the vaccine? And again, there will be expected side effects like those arm swelling and the fevers, and there will be people that have allergic reactions. In their studies, they reported somewhere in the 0.5% allergic reaction rate for the Pfizer vaccine. So I just want people to recognize that the incidence of allergic reaction to peanut butter is 1%, just to put it in perspective. What are not the vaccine side effects? Cancer, growing a third arm or a third eye, alteration in your DNA. And again, this is because the proteins and the molecules that are put in your body with that mRNA vaccine are degraded rapidly. And at the end of the day, all that's left is that antibody immunity. And it's really just based on that initial immune reaction. And then everything's gone. And it's not altering your DNA. I'll just leave this up here for whatever crowd participated in activities like this. But there are many worse things that many of us put in our body or have put in our body that I can promise you are a lot worse than whatever's in that COVID vaccine. The herd immunity, just I think a nice depiction. And we're at the end, everybody. Thanks for listening to my medical jargon. But on the top of the picture, the blue are the people that are healthy and not vaccinated. The yellow are the people that are vaccinated, and the purple are the sick people. And you see that if only a few people get the vaccine, pretty quickly the virus can still spread amongst the crowd, as opposed to on the bottom picture. If most people get that vaccine, then almost everybody is going to be protected, and that's what we want. And final thoughts, we are stronger together in everything that we do. If we're kind to each other and support each other, it's impactful. I will say that in the spring, when there were people, driving by and honking their horns from outside the hospital, that personally kept me going. It just, you kind of like anybody else's job, you go in, you do your job, you just think it's normal. And that recognition, I think kept a lot of nurses and doctors and, other healthcare workers going because they felt appreciated, and everybody wants to feel appreciated in what they do. Let's be responsible. The beginning of the end is near. It's in the air. I can feel it. Be a role model. And then, just thank somebody for what they do, whether it's the folks at Newcastle trying to keep you safe, a nurse, a scientist, a janitor, people are putting themselves out there to keep us all safe, to keep food on our tables, gas in our cars, and the appreciation goes a long way. So that is all I have. I'm happy to take any questions. I can.
Dr. Cohen, thank you so much. That was incredible. I was hanging on every word. I'm telling you, that was a really brilliant overview of what's going on right now in the situation. Maybe while people, we've opened up the chat field, so go ahead and you can start typing your questions in, and maybe I'll throw one out there to sort of get the ball rolling, if you don't mind. You mentioned hospital burnout early on, and then in a certain sense, you circled back to it at the end when you talked about sort of the impact that was felt by, folks driving by and honking their horns and so on. I'm curious if you're continuing to feel that kind of support from the community today, or if you think there's a role that the community could be playing to help combat sort of burnout right now.
Thank you. It doesn't feel the same as it did in March, and I wouldn't expect people to keep up that level of enthusiasm. And people are working now, and they're in school. They have better things to do than drive by the hospital and honk their horns. But I will tell you, in the last 10 years, I probably cried 3 times at work, and I probably cried 15 times this year. Just, seeing that appreciation was really, really impactful. And again, I think like anybody, when someone says thank you for what you do, whatever it is, people really appreciate it. So I think it's just one way, out of the many, that people can keep their mental health strong and keep going. We have to keep going. There's no other option right now. Thank you.
Thanks.
I'll go through the chat box. The first one was, the person has a child with an underlying condition, and at which point will he be in line for a vaccine? Are the pediatrician offices going to receive the vaccine by the spring? And when is it appropriate to call to understand the priority? So I think that there will be limitations with who's going to get the vaccine, forgetting even, frontline workers, elderly folks. As of now, my understanding is that people that are pregnant, people with autoimmune disorders, children are not approved to get the vaccine. And that's because they have not studied or done research on those folks. I know that throughout the course of the year, they will plan to research on children. And I would expect that at some point by the late spring or summer, children will be approved to get the vaccine. I'll line my children up. As far as having underlying conditions, I think that we need to see more research about how people do if they have, especially the autoimmune things like a rheumatoid arthritis or Graves' disease. Those are things where your immune system can act a little funny, and we just don't know what the response is going to be to the vaccine for those people. I would say with a child, just kind of stand by, and I would expect that in early spring we'll have a lot more guidance, but I don't think children are going to be getting vaccinated at any time in the next, 3-4+ months. The next question is, with viral spreading, which can last a week, is a person still contagious? And the answer to that is typically from the time of onset of symptoms for 10 days, you're going to be contagious. And everybody's going to be a little different, but that's generally a pretty safe range. So that's that 10-day period from when you get symptoms, and at least 3 days from when you no longer have fever, you should consider yourself contagious. The next one's from my neighbor saying thank you. Thank you, Lori, for joining. The next one is, how reliable is the antibody test? I heard it wasn't that accurate, but that was a few months ago. I agree. It's kind of, the antibody test has fallen out of favor as far as it definitely, I do not believe that it has a role to detect acute illness and infectivity. If it's positive, my feeling is that you probably did have SARS-CoV-2 at some point. But if it's negative, I think it's less helpful. And that's because there are multiple different types of immune cells in your body, and the antibody test really just looks for 2 of them. And so I wouldn't hang your hat on it, other than if you thought you had COVID and it was positive, you probably had COVID. Um, Again, it may, if you're someone who wants to kind of wait and be a late adapter of the vaccine, personally, if I knew that I had had COVID last week, I might say, I'll wait and let someone else get the vaccine and I'll take it in February instead of January. But other than that, I wouldn't, make a lot of decisions based on it. Lori says, when all the vaccines are available, how will we know which one is best to take, or will it matter? We'll know from reading the news and watching people like Dr. Gupta tell us, and listening to podcasts and talking to your doctor. And I do think it's going to take like the village of pharmaceutical companies to get us vaccinated. And like personally at our hospital, we're going to take what New York gives us, and New York is going to stratify who has the special freezers that can go to -90 and who doesn't. And that's how they're going to decide who to distribute different vaccines to. At whatever point we get to where there's a glut of vaccines, that may be June, it may be June of 2022. That's when you may have more like consumer related decisions. My guess is like our individual doctors' offices and CVS's will have one type of vaccine to offer based on availability and storage concerns and costs and things like that. And again, at this point, I have not heard of any vaccine that's even nearing that emergency authorization stage that I would have any hesitancy to put in my body. Are men still getting this and getting sicker and at higher rates than women? There's a lot of still unknown. I do think men are on average getting sicker. But again, the kind of COVID is not just following all the rules and following the textbook. And so it's still kind of anybody can get COVID and get sick from it. But yes, we're seeing more men on average than women. Gonna keep going through. And then IV, at any point, we've exhausted or whatever, you can give me like that sign.
I think you're gonna have to be the one to tell us you're exhausted. You're doing an awesome job of responding to all these questions. I'm amazed.
Thank you. Can you speak to the details of the allergic reaction and how one should proceed? So, this is like hot off the presses. This just happened yesterday. I was trying to find out how many people got the shot because you had 2 people that had an allergic reaction. I can tell you that on a typical shift in the ER, I see 2 people with an allergic reaction. I don't know if they needed adrenaline or intubation or hospital admission, or they got hives. And so we're going to learn more about this over the coming days. But the guidance that I'd read so far this morning from Pfizer in the United Kingdom is that if you have a history of severe allergies, and that doesn't mean like to pollen, you get sneezy. That means bee stings, you get anaphylaxis, or peanut butter. You're more likely than others to have a serious allergic reaction to something else, whether that's, honey or, milk or whatever. You're somebody that's at higher risk. And Pfizer and the United Kingdom said, just hold on, let us figure this out a little more. And I think that's reasonable. And I don't know how long that's going to be. Is the RNA in the vaccine specific to the coronavirus, or could the body use it to create a dangerous antibody? And yeah, I think that's a good question. It's specific. It's a message to our body to create the protein that looks like the spike protein. And so the antibodies that will be created will be specifically targeted to kill spike protein. And that's it. And they should not be targeted to kill your heart or your joints or anything else. And, I think fortunately for most of the general population, there's going to be 20 or 30 million doses given before the typical person has access to the vaccine. So if you see me on the street and I have a third eye, hold off. But otherwise, the data will be out there, overwhelmingly, but, so far in the 30, 40, 50,000 people that were in the trials that got the vaccine, they just didn't see anything that looked alarming to my knowledge. And again, that's part of what our FDA is doing this week, is double checking that. And if it looks dangerous, we're going to hear about it. COVID-19 for children, we spoke about that, in pregnant women. I think that pregnant women, they're never going to do trials on. Drug companies don't like researching on pregnant women. They think it's not ethical. And so my guess is that if you're pregnant, you're not going to get the vaccine for a long, long, long time, meaning nine months plus your breastfeeding time. If you're traveling and you need a PCR test 72 hours before leaving, where would you suggest? I would suggest checking on Chappaqua moms. I'm not that in tune with the local, because I work in Orange County. I'm not that in tune with the local. I will say, I've heard stories of people waiting 8 or 9 days for their result. I mean, it's just, we need more tests in our world, for sure. It's just not fair to make someone wait that long. Adrian says, I've heard the side effects are more common and severe than flu vaccine, but similar. Isn't it important for people to be prepared to get sick? Yeah, I think that's a great point, Adrian. And as we prepared our hospital to vaccinate our healthcare workers, we're going to stagger how people get them, because I certainly can't have 7 emergency doctors all get sick with fever and body aches on the same day. So absolutely. And definitely do not skip that second dose. As Adrian said, it's either 21 or 28 days after, depending on the type of vaccine you're getting. And that's really important. Does the flu vaccine reduce the impact of severity of COVID symptoms? I've never heard anything to suggest that that's the case. And then Barbara writes, if my husband's large office developed COVID, what would be the next step my husband should take? The person felt sick yesterday. So this is like one of those, there's 75 million different situations. How far was your husband from this person? Was your husband and this person wearing a mask? I would say if they were within 6 feet or so for a prolonged period of time, meaning more than a minute, 2 minutes, and they weren't wearing masks, that's a significant exposure. But if your husband was 100 yards away and he was wearing his mask all day, I would not consider it an exposure, other than it's out there in the community, and take standard precautions. In terms of school, is it safe to send children to school as the numbers are rising? I'm still sending my children, and nothing. The only thing that's perfect is, again, to lock yourself in your basement and don't come out. And otherwise, there is individual risk tolerance that we all have to take. Again, Zoom school was torture for my wife and I, and we think it's worth it and it's safe. And I think the schools are doing a phenomenal job. The transmission does not seem to be within the school. It seems to be, we're putting ourselves in situations in the community, and then the school is notifying us and telling us, and they're shutting it down. And so, again, nothing is 100 or 0, but I think they're doing a great job. Eric says, some discussions regarding the vaccine show a concern that we may be unaware of long-term effects, especially since they've been fast-tracked. How certain can we be about the long-term? So the fast-track, in my understanding, I'm not a researcher, really had to do with the government, giving these companies the money and assurance that they can produce large quantities and build factories, even though they didn't know how their phase 2 and 3 trials were going to turn out. And so the companies could kind of do those steps without waiting years for their trials. One of the other reasons the trial went quickly is because, luckily for Pfizer and Moderna, so many millions of people had COVID that they were able to reach the number to be statistically significant pretty quickly. And they were able to, to get their numbers quickly and make a determination that they thought was significant. And I think those are the reasons it was fast tracked. I'm not aware of any long-term side effects, but I do think that getting COVID has high risk for long-term side effects. And again, everyone's got to make an individual risk, but I will definitely take the risk of the vaccine side effects against the COVID. And nothing is, I don't have a perfect decision or a perfect answer. And if you come back to me in 10 years, I'll tell you. But until then, I don't know. Ivy put a resource, thank you. And then Jill said, do you know of severe allergic reactions that occurred at the time, right at the time? I don't know that either. I know that, there are recommendations from the companies where you have to monitor people for at least 15 minutes after they get the shot. But I don't know if the reactions occurred 15 minutes or 5 hours later. Alice says, definition of a bubble. None of my grandchildren have seen anyone outside their house for weeks. I watch a grandchild in the mornings. Their father does work outside the house, wears a mask. Is it okay for me to see my grandchildren with the air purifier and the mask, and grandson does accept eating? Are we safe? Again, I think that's pretty safe. The more context your bubble has, the higher risk. And again, it's not zero. But as somebody, that loves to see my children with their grandparents, I think calculated risks may be appropriate for individual families. But then, the discussions need to be there with your family that, you're taking a risk by seeing the grandchildren and they're responsible for you now. That's a big responsibility. So, making sure that it's done in a safe way, I think is really important. Will the webinar be shared later? Ivy, I believe it's going to be shared, right? Okay. I'm going to do one or two more, and then I have no voice left. So
yeah, I was just going to say that we've gone over the hour. So thank you so much for all the time that you've given us. I appreciate it. If you can take one or two more, that's great.
Absolutely. The last one from Brian is, how do you expect the year's flu season to be impacted by COVID? It's amazing. I have not seen a single case of flu yet in my hospital in Orange County. I know Western New York flu is starting to spike, but I think that the kind of half great measures that we're doing for COVID have been enough to really stem flu, but not enough to stem COVID. I do think flu is coming, and it'll just add to the kind of chaos and number of people that are going to get sick. And I would make a push for everyone to get their flu shot if they're able. Ivy, I'll end it there, and then I'm happy if anyone wants to, email me questions to do that. And I really appreciate people taking time out of their days to listen to COVID and our knots and herd immunity discussions. Thank you.
Thank you so much. This has really been an incredible hour, and I've learned a tremendous amount, and I really can't thank you enough for stepping up and for your service to the community. Thank you for being one of our first responders and for being out in the field this whole year. It's incredible, and for you to take your free time to do this is also really amazing. So thank you so much. We really, really, truly appreciate it.
Yeah, thank you so much. This was great.
Thank you. Bye-bye.
Bye now. Thanks.